wonderful. And in the month of, say, July, the IPF Women's Wing will be doing one another webinar, and in June, most likely the IPF will be doing it on a different topic. Of course, you all are part of IPF also, so don't try to segregate yourself from IPF. Basically, we all are from IPF, and this additional responsibility has been given. And one thing more I wanted to tell, that in this conference also we will have 2 hours, 2 hours, say, session from IPF Women's Wing. And in the brochure, you all must have seen that various universities, various institutions from India and abroad, they have all joined as collaborators or in association with, along with the Royal College of Physicians of Edinburgh. And now we have a request from the GAPIO. You all must have heard of the this uh, Global Association for Physicians of Indian Origin. GAPIO is very active, and they also have their webinars and their annual conferences. So that we have got a request from Gabio, and I will be Gabio, and I mean a day or two we will having a meeting with him, whether they also want to join with us in this IPF Medicon 2026. So the President Dr. Surjadeep Sen Gupta has given me this responsibility to welcome everyone. So I welcome each member of IPF and all other guests also who have joined to this important webinar. And this is also being transmitted on the YouTube channel, which has also been shared. Dr. Satnam Chavda, our member of Innovative Fusion Forum and also the chair of the Department of Neurosurgery and Neurospinal Surgery of Sarangaram Hospital, he has also joined. So I think it is already 8:35.
I think we can
So
start.
I welcome everyone, and now I hand over to Dr. Princey Jain to take over the further proceedings. Thank you.
Thank you, sir. Good evening, everyone. Our distinguished speakers, guest faculty, and esteemed members of medical fraternity. A very warm welcome to you all from the IPF Women Wing, which is a baby of Innovative Physician Forum, for joining us for this webinar today. The topic is of immense importance and clinical relevance to us as physicians. Type 2 diabetes, type 2 diabetes and sarcopenia in women, current understanding and clinical implications. IPF Women Wing has envisaged as a platform that combines academic excellence with empathy driven healthcare, which is our goal also. And it's my privilege to introduce to you all our President, Dr. Surjadeep sir, and JK Sharma sir, the General Secretary and Global Ambassador of IPF, under whose vision and guidance the forum continues to champion the cutting edge medical education programs. Sir, kindly address the gathering with your words of encouragement and visionary guidance.
So thank you, Dr. Princey. As I have already said, that we started this innovative fusion forum in March 2017. And in these 9 years, it has been gone at the level of the international, and we have around 515 members. And we started the associate membership also, and we have got 3 or 4 associate members also. And our motto is for education, for academics, and the scientific programs, which you all have been saying. And I welcome everyone, and please participate actively. And with that, I'll not waste time. Thank you very much, Dr. Princey, and everyone. Thank you.
Thank you, sir. Now I invite our esteemed chair, gorgeous Dr. Meena ma'am, to take the podium and lead us into the course scientific segment and introduce our expert faculty for the evening. Meena ma'am.
I think you can carry on with the introductions. just carry on with the introductions. Give me 1 minute.
Sure, ma'am. So, our our first speaker is Dr. Sunita ma'am. She is the professor at Maulana Azad Medical College. Sunita Agarwal ma'am. She will be talking about she will be talking about the first segment of the program, which is the uh, current understanding of this topic about type 2 diabetes and sarcopenia in women. So, ma'am, welcome to the Innovative Physician Forum Women Wing, this second webinar. Kindly take over the podium.
Thank you, Dr. Princey. First of all, I would like to thank all the organizing committee of this. I want to share my slides. When maintain the current size. Yeah, maintain. When to share. Choose the individual. How to share, Princey? Yeah, share screen. No. In the setting, they are asking. Yeah. Are you able to see my slides? Hello?
No, ma'am, it's not visible to us.
Yes, now it is visible. Now you can go to slide show mode.
Slide
Go to
show mode.
slideshow mode. Yeah.
Yeah. Thank you, everyone. First of all, I would like to thank you, Dr. Princey, and the other organizing members of this innovative physicians forum. I would like to say it is a very innovative idea for this women because we faces the different challenges as compared to men. There is some, I don't say ki we are facing the different diseases, but still we have the different aspects in every disease. So without wasting our time, I'm starting my presentation. Topic given to me by Dr. Princey is the type 2 diabetes mellitus and sarcopenia current understanding. In this topic, first of all, we should know what do you mean by sarcopenia. Sarco means flesh, penia means less flesh. It is a basically disease of older person. It is an age-related disorders which is characterized by low muscle strength, which is very important or essential criteria, which is added by the low muscle mass. Then it should be for the severe sarcopenia, the patient should have the reduced physical endurance, less physical activity, limited physical activity. If I say ki what is the global prevalence of sarcopenia, I took the help of AI, which shows the overall prevalence 10 to 27% according to European working guidelines of sarcopenia in older patients as well as the Asian working in depending. There are some different diagnostic criteria, but overall studies is the 10 to 27%. Out of these 2 to 9% suffering from the severe sarcopenia, we label the patient severe sarcopenia when it is associated with less physical endurance. Presence of low muscle strength, low muscle mass is sarcopenia. When associated with less physical activity, it is severe sarcopenia. It has some regional variation globally. If I say the Oceania, mean the Australia, New Zealand, higher prevalence as compared to Europe. In the age factor, of course, it is a more common in older individual more than 60 as compared to younger less than 60. Gender difference, international working group says women have higher prevalence, but European working group say that is the men have higher prevalence of sarcopenia. If I would say ki what is the prevalence in our country, this is the basically, of course, I have taken the help of again the AI, in which the patient who live in the community, older individual 8 to 18%, but patient who are the hospitalized, when the study is done, it may be up to 40% because they are suffering from many disease, CKD, CLD, COPD, like that. It is more common in rural as compared to urban. Reason they have not defined, maybe it is the more the awareness and the more physical exercise, mainly the isotonic exercise, more nutrition, less carb and high protein. More common in older individual as compared in the 40 plus sarcopenia is just 4.2%. But in India, it is this data clearly shows the men have the more sarcopenia as compared to women. In diabetes, this is the meta-analysis which is published in 2022 in Journal of Cachexia, Sarcopenia and Muscles, where the more than 150 studies were included, and they have compared the different criteria of sarcopenia. In these meta-analysis, they reported that the pooled prevalence is 18%, however, range is 7.2 to 31%, and it is more common in Asia as compared to South America. This study was done in sarcopenia in diabetes, which is published in 2025, in which the around 26,000 participants were included. Out of this, around 800, something like that, they were diabetic, and they showed the wide variation about the community-based and hospital studies. And they shows that the hospitalized type 2 diabetes have the prevalence of 26.7. Just imagine 26, more than 1/4 of the population is having the sarcopenia. Still this disease is still not, we are not so much aware, we are not putting still diagnostic criteria when the patient is hospitalized and when patient coming to the OPD, it is an underdiagnosed till date. And even in the diabetic adults, they found the 62% sarcopenia, and this is the sarcopenic obesity. Basically, the patient is sarcopenia, but still having the more weight. In diabetic, they have the prevalence of 44%. By definitions, I would say primary sarcopenia, it is just age-related. Secondary sarcopenia, secondary to disease, maybe CKD, CLD, COPD, even basically bleeding disorders, even in the diabetes. Even I have done one study, sarcopenia and hemophilia, because I am looking after the hematology clinic. It was found, it was just 1 year thesis part. Out of 50 patients, 80% have patients have sarcopenia when they were on the episodic therapy. But with the physiotherapy and the regular replacement therapy, this comes down to 40 to 50%. But it is more attributed to because hemophilia is a musculoskeletal disorder which can which have the more prevalence of sarcopenia as compared to other diseases. Some say it is an acute or chronic sarcopenia. Acute when it is less than 6 months. Many patients like the poisoning and patient, they are admitted in the ICU for so many things, snake bite. They have the less muscle bulk, less muscle strength after ICU and the prolonged hospitalization due to fracture after surgery. But they recover very well when the nutrition and exercise and the rehabilitation program are given to them. Chronic sarcopenia, when the sarcopenia persists more than 6 months, it is always associated with chronic disorders we are facing. These are the sarcopenia-like conditions in which the sarcopenia is present, but still we underdiagnose. That is the sarcopenic obesity and frailty. What is this sarcopenic obesity? In the sarcopenic obesity, patient appears obese. It seems they don't have any problem. But when you see the muscle mass, there is decreased. In the frailty, it is the basically interchangeable term but still distinct because one is geriatric syndrome, other is a disease. In the frailty, it is the not only the musculoskeletal health, but it is the cognitive and the social dimensions are included. So these are the sarcopenia-like syndrome in which the sarcopenia is an important part, but still little difference. If I would say the risk factors, age-related, we all know as the age progresses, there is decrease in the change in the hormonal profile, decrease in the testosterone, estrogen, age-related cellular changes, especially at the level of mitochondria, neuromuscular disorders, whatever the hormone, more resistance. In the secondary causes, I would say in spite of the chronic disease, which hampers our muscle mass and the muscle strength, still decreased physical activity and dietary habits, they make an important role in sarcopenia, in which the less protein, vitamin deficiency, alcohol, smoking plays very important role in sarcopenia. This is the just slide I want to highlight how important is the physical activity. Just see, this is a 40-year-old athlete. This is the 70-year-old athlete. No difference or very little difference in the muscular mass. But this is the sedentary. Lot of fatty tissue at the age of 74 and less muscle. Means even the quantity or weight is same, but still have very less muscle mass, showing the importance of physical activity in our life. Most of us just giving the excuses, we don't have time, we don't have, so we cannot do this. But remember, females needs more physical activity for sarcopenia because we are more susceptible. In the chronic disease, we have already discussed systemic disease, diabetes, CKD, endocrinal disorders, autoimmune disorders, neurological, and especially the cancer and the chronic steroid release due to any reason can lead to sarcopenia. Now the sarcopenia and the diabetes mellitus, they are every factor is contributing as the age progresses. But for the diabetes, it is the insulin resistance which makes difference for the development of sarcopenia in diabetic, which accelerates the sarcopenia, in which there is a decreased glucose uptake in the muscle, leading to decreased protein synthesis, and how along with there is a chronic inflammatory state with diabetes, so there is an increase in the inflammatory cytokines like the IL-6 and the TNF alpha, and due to the insulin resistance there will be the fat infiltration in the muscle, lead to the myostasis. Of course, it is associated with the reduced physical activity, hormonal mitochondrial dysfunction, lead to sarcopenia. Message is muscle is a large glucose sink, we all know. So myostasis accelerate the sarcopenia or it turns into a vicious cycles. This is again a diagrammatic presentation. We have already discussed all these changes: obesity, scleromyostasis, mitochondrial dysfunction, low physical activity lead to the degeneration of the skeletal muscle and the myostasis. Insulin resistant inflammation, impaired contractility contribute ultimately lead to development of sarcopenia. This is again showing the various pathophysiological mechanism showing leading to the development of sarcopenia. Again, this is the dramatic presentation. Glucose intake ultimately lead to the decreased protein synthesis, increased catabolism, muscle wasting, ultimately contributing to sarcopenia. So remember, diabetes accelerates the process of sarcopenia. So we have to address at an early stage to prevent this. Once it develops, we have to work, of course, over it, but prevention is the key, so that the physical, they should not be physically disabled. This is the study basically showing the role of various anti-diabetic drugs, showing the effect on the musculoskeletal health, in which is clearly shown that the metformin and the thiazolidinones, they increase the muscle mass, DDP4 increase, insulin decrease, sulfonylurea decrease. So the patient come with diabetes in the sarcopenia, we should be aware which anti-diabetic drug we have to give. We have so many drugs in our bucket now, so we can choose if we diagnose the sarcopenia at an early stage. Now the sarcopenia in women, it is different or it is same? Of course, age-related changes will come, but in women, when you reach the perimenopausal phase, we all know estrogen decreases, so it accelerates the sarcopenia due to the fat distribution and the muscle breakdown. And we have female have the baseline less muscle mass, which alone a contributing factor for the sarcopenia in women. This study was done sarcopenia in the menopausal women, in which they have shown that menopause is associated with hormonal changes which could accelerate or lead to sarcopenia. Functional impairment and physical disability are major consequences of sarcopenia. Remember, estrogen is a protective hormone for us. Once it is less, then we are prone to many diseases, cardiovascular diseases, musculoskeletal, even the decreased muscle mass. This is the basically highlight of this article again. Due to the physical changes, there is a change in the muscle architecture and the muscle composition because there is a more fat infiltration. These hormonal changes ultimately lead to sarcopenia in women. So diabetic, perimenopausal women, these are the again two contributing factors for the development of sarcopenia. We should screen these patients for sarcopenia. I don't think so in many diabetic clinics we are still following the screening methods for sarcopenia. So how to screen them? First, we have to say the first component is muscle strength. So according to this, we have used the dynamometer, which is very easily accessible and not costly. It basically assesses the hand grip strength. According to European Working Group, in men 27, women 16, little bit different in Asian 28 and 18. There are the many guidelines and they are the different parameters we have to see which parameters we are following. According to us, we should follow the Asian Working Group Sarcopenia, because we are different from the European, basically US and UK female, because they have the different body structure, different insulin resistance, different lipid profile as compared to Indian women. For the muscle mass, we can use various parameters like the DEXA, CT, MRI, by BIA and anthropometric methods, but there are some pro and cons for every investigation. DEXA very handy, inexpensive, measures the appendicular skeletal mass, but it depends on even the hydration status of the patient. CT, MRI not easily available. When it is available, a patient want to spend over it, it is a win. But these are the gold standard because they can show the myostatosis also. This again, the BIA is we can do easily, but it also affected by volume status. Anthropometric method, they are the good for the screening, but not for the confirmation. These are the anthropometric mid-arm circumference by the European guidelines, less than 28.6 in male, less than 27.5 in female. Calf circumference is less than 31 centimeter. It would say कि decreased muscle mass. Body mass index can't differentiate between muscle and fat. Lack standardization. So we will not recommend for sarcopenia. It cannot differentiate between the sarcopenic obesity and obesity. For the muscular mass, even we can show the appendicular skeletal mass index, in which the muscle mass is seen in the limbs, in which the European 7 and 5.5, according to Asia 7 and 5.4. When you have the low strength and low mass, sarcopenia is confirmed. Remember, this is the hand grip test, muscle strength. Then you either go the anthropometry, depending upon what center you can do, or go for the ultrasound, DEXA, CT or MRI for the muscle mass. It means sarcopenia is confirmed. Then how to test this physical performance? There are the various tests: gait speed, short physical performance battery, timed up and go test, chair test. This is the gait speed. I will not go into the detail. It is the 4 meter usual walking speed, in which the stopwatch is used, and speed less than or equal to 0.8 meter per second, it is considered less physical activity. In 400 meter walk test, it tests the endurance because it is a 400 meter. Walking ability, 20 laps of 20 meters, each lap as fast as possible and allowed to stop. This is the times up and go. Stand up from the chair, go for the 3 meter, turn around and again sit. Then if it is the disturbed, then you can check the physical activity. Then it is the short physical performance battery, in which you test the balance test, gait speed test, 5 chair stand test. It is the combination of 3, score 12, and if it is less than 8, then you consider that physical endurance is low. We can apply any thing depending upon the convenience, and every test has the can test the physical endurance. This is the guy, basically one slide showing the sarcopenia cutoff given by the European Working Society, in which the gait speed, short physical times up and go test, 400 meter test, muscle quantity is everything is summarized. When you confirm the diagnosis by the low muscle mass and low muscle strength, physical endurance, if they are different, that confirmed it is the severe sarcopenia. But what is the screening tool? We cannot screen each and every patient because in the government hospital it is very difficult. We have the so much workload. So then for the muscle decline, just we can apply this SARCAF questionnaire. It is a screening tool for the sarcopenia. It tests the strength, walking assistance, chair rise, stair climbing. Have the two points for each. If it is less than 4, then it is confirm the more than 4, it confirms the it is sarcopenia. This is the basically just a methodology. If we can go for it, clinical suspicion, apply this SARCAF questionnaire. If it is positive, go for muscle strength, do the grip test. If it is negative, no need for we could say I will rescreen later. At present there is no sarcopenia. If it less muscle strength, sarcopenia is probable. test for the muscle quality or quantity by any method. If it is done, then the sarcopenia is confirmed. After sarcopenia is confirmed, test the severity by any test, gait speed, physical SPPB, TUG, and 400-meter walk. It means the severe sarcopenia. These are the various articles because I was given the topic, the current understanding. So I will not go into the clinical implications. This is the next topic which is will be covered by Dr. Swati. These are the various articles published by, on the type 2 diabetes and the sarcopenia as a comorbid chronic illnesses, which shows that the less physical activity and exercise intervention major contributing factor for the type 2 diabetes mellitus and sarcopenia and the myostate. They have shown the some innovative therapies also in this review article. In this article, which is published in 2021, prevalence and the risk factor for the sarcopenia in the diabetes, again they have showed it increases with the diabetes, age, HbA1c, fatty acid, nephropathy, duration, HSCR. They are all associated with increased sarcopenia in this study. In which this study was again published in the 2023, in which it is again describe the pathophysiological mechanism, insulin resistance, chronic inflammation, accumulation of advanced glycation products, oxidative stress. All of them are negatively affect the skeletal muscle mass, strength, and functions, leading to type 2 diabetes mellitus and sarcopenia. This is again the review article in which they have tested, they have clearly mentioned that when the patient type 2 diabetes and the sarcopenia, it has a very poor quality of life, and it is a increase the mortality in type 2 diabetes mellitus. So we have to be aware about it. We have to screen so that at least quality of life is not compromised for these patients, especially with the physical exercise and the just nutrition which is advised to these patients. In which in this article they have done the pathogenesis and the comprehensive treatment strategy, in which they have clearly mentioned that you cannot ignore the dietary and the physical activity, but early identification and comprehensive treatment, you can improve the muscle function and ultimately leading to quality of life in patient with diabetes and sarcopenia. Clinical feature, just we have already will be covered in the next by the next speaker. EG fatigability we have discussed, all these climbing stairs, slow walking, difficulty in getting up, all these. So management, exercise, nutrition will be covered, I think, in the next session. Glycemic control is an important point, because the advanced glycation product ultimately lead to more muscle breakdown. We have already seen there the pathophysiological mechanism in the muscles, and we have will be covered. Targeting therapy, myostatin analogs is the done. I think it will be covered. Then this is the basically international clinical practice guideline for sarcopenia. They have clearly mentioned when to screen the patient for sarcopenia. Older patients, 65 or older, should be screened for sarcopenia before and after the occurrence of major health events. Screening of sarcopenia can be performed by the questionnaire or gait speed. Individual screened as positive should be referred for further assessment to confirm the disease, that is the either ultrasound, CT, MRI, DEXA, or anthropometry, depending upon the availability, to confirm your sarcopenia. The take-home message is sarcopenia is significantly more common in patients with diabetes as compared to general population. Globally, 18% of the diabetes are suffering from sarcopenia, but Indian study shows the higher prevalence. Poor glycemic control, longer diabetic duration, older age, they are the contributing factors. It worsens the disability, frailty, cardiovascular risk, especially when combined with obesity. Routine screening in diabetic patient is essential for early detection. Lifestyle intervention, resistance exercise, adequate protein intake, optimized diabetic management are the cornerstone for the diabetes control also, as well as for treatment of sarcopenia. Addressing sarcopenia and diabetes can reduce morbidity, improve quality of life, and ultimately it will lead to lower healthcare burden. Thank you very much. Thank you.
Thank you, Sunita ma'am, for such an excellent and thought-provoking presentation and shedding so much of light on this topic. So now we proceed to our next segment, which is the clinical implications of type 2 diabetes and sarcopenia. It will be taken up by Professor Dr. Swati Srivastava ma'am. She is the senior professor and unit head of SMS Medical College, Jaipur. And ma'am is also the present governor of American College of Physicians, India chapter. So welcome, ma'am.
Thank you very much, Dr. Princey. Is my screen visible?
Yes.
Yes, ma'am.
Okay. So thank you very much. At the outset, I would like to thank the entire team IPF for giving me this opportunity. Dr. J.K. Sharma, Dr. Princey, Dr. Meena Chabda, Dr. Divya, and Dr. Surjadeep, the entire team for this interesting program. And I'm so happy and privileged to be here. And they're discussing this very important topic of current relevance. As we see that sarcopenia, Dr. Sunita Agarwal has quite in detail described about most of the factors of sarcopenia. My work is mainly to look into the clinical implications, and that's what I will be discussing. So what is sarcopenia? As Dr. Nita said, it's a progressive age-related loss of skeletal muscle strength, mass, and function, which leads to disability and mortality. So basically something which is occurring normally as an age-related, but because of the presence of so many other comorbid conditions, as very well highlighted in the previous talk, like type 2 diabetes, any chronic disorder, cirrhosis of liver, CKD, COPD, any chronic disorder, infective chronic disorder, hematological chronic disorder, may accelerate this occurrence of sarcopenia and may bring it much, much before than what we consider as the in an earlier age group. So if we look into it, the main key characteristics is a progressive decline in the muscle mass and function. There's an increased risk of falls and frailty, and it has a complex multifactorial etiology. So here, as we say, this age-related, we probably now are not very happy with that, because we know that the occurrence of so many other disorders which are increasing in epidemiology these days, like type 2 diabetes being one of us, which we're discussing today, we have much, much before and not just age-related. What is the burden and impact? The prevalence rises with age and varies by criteria, but there's a substantial impact on the healthcare cost. There's a 25% prevalence, approximately, we could say. Some studies in India show much higher, especially in women also. And other studies may have a little variation, but approximately a prevalence of almost 1/4 of people of the rising age having sarcopenia. Important is a 40% fall risk and a 60% disability. So a 40% fall risk becomes very difficult because the people, they tend to fall, and then followed by so many other problems, fractures, other hospitalizations, and so many other complications come. If we look into the hallmarks of aging and sarcopenia, so there is an entire, the stage which our muscle and our body goes through as we age. We know as we age, there are so many genetic and biochemical pathways which influence our age trajectories. I will not be speaking too much on this, as I have to talk about the clinical implications. But as we age, there is genomic instability, mitochondrial dysfunction, cellular senescence, stem cell exhaustion, altered communication. The reactive oxygen species and the DNA damage are one of the key pathway interactions. Is senescence, is denervation, atrophy, and age disruption. So these are something which occur as age-related normal processes. Now, what happens in diabetes? So though we say that sarcopenia is classically related to aging, as my previous speaker also said, that certain disorders, especially when we talk about, today we are talking about type 2 diabetes mellitus, it specifically accelerates the development of sarcopenia. How? One important factor is insulin resistance. So insulin resistance is a very important factor which contributes to sarcopenia. Inflammation, interleukin-6 and other inflammatory markers have a negative impact on the muscle, leading to sarcopenia, loss of the muscle mass, accumulation of advanced glycation end products, oxidative stress. These are some of the large number of factors which are there in type 2 diabetes, which leads to development of sarcopenia. Now, what happens because of sarcopenia? If a diabetic develops sarcopenia, what happens? It then affects its muscle mass, strength, protein metabolism, vascular, and mitochondrial dysfunction. So all these things occur because of these pathogenic processes which are occurring in a diabetic patient. And hence, a good control of type 2 diabetes is one step we take towards the prevention of sarcopenia, because we could be preventing all of this. It is interesting to note that complications, microvascular as well as macrovascular, tend to occur more in patients who have sarcopenia. So it is not only related to the muscle mass, but it has an impact on the entire prognosis and the course of the disorder in the patient. It's interesting to know that the other way around is also important. We said that type 2 diabetes leads to sarcopenia. Let us realize that sarcopenia also is bad if someone has sarcopenia due to any reason. For example, someone has a fracture or is bedridden for any reason, it further will aggravate the diabetes as well. So loss of the muscle in sarcopenia through the decreased productions of myokines play a role in the glucose and fat metabolism and leading to development of type 2 diabetes. So it is a bidirectional phenomenon. It travels in both the directions. So it's multifactorial. Now talking about the clinical diagnosis. Now you realize that this patient could be having sarcopenia. Now what should we do? A clinical diagnosis of sarcopenia might also include functional limitations. The functional limitations, so one is muscle mass being less in quantity, less in quality, increased falls, and a functional limitation, or what we say as a disability. Maybe the patient doesn't realize that he has a disability, but it's a functional limitation. What are they? Slow walking, difficulty in rising from chair without hands, or walking upstairs. This we will talk and discuss in more detail in the next coming slides. So what happened is, when this definition of sarcopenia was given and the sarcopenia realization occurred many years since the past 2 or 3 decades, the European Working Group on Sarcopenia in the older people, the EWG-SOP1, they then updated to the second EWG-SOP2, and they gave the definition of how should we say that this person is sarcopenic. So there are basically 3 criteria. One, as I said, is a low muscle strength, a low muscle quantity or quality, and a low physical performance. These are the 3 important things. Now, when there is a low muscle strength, when do we say it's a low muscle strength? Simple is a grip strength. Grip something. We have the 16 kg is, if the grip strength is below 16 kg, and or a chair stand is more than 15 seconds for 5 rises. We will discuss in detail ahead what I mean by this. And a low muscle quantity or quality defined as an appendicular skeletal muscle mass less than 15 kg or less than 6 kgs per meter square. So if we see the cutoffs for the low physical performance, when do I say that this patient is performing okay and this patient is not performing? So, okay, maybe he has sarcopenia. If his gait speed is around 0.8 meter per second. So 0.8 meter is a small, distance. We walk in approximately 2 steps or something like that. So in 1 second, if he is not able to walk so much, that is one thing which is important. Then, as my previous speaker also said, the short physical performance battery, this I'll discuss, is less than 8 point score. Then the timed up and go test, more than 20 seconds, a non-completion of or greater than 6 minutes for completion of a 4 400-meter walk test. Now, if one has to do a 400-meter walk test, that's also a short distance. If the person takes more than 6 minutes, it becomes important. Why is he so slow? Unless he has some neurological disorder, he should not be so slow. So if the first criteria alone is there, it's a probable sarcopenia. If there is additional documentation, as second is also there, we confirm. And if the further all the criteria are met, then it's a severe sarcopenia. If he's not able to do all of these, if all these criteria are met, the sarcopenia is severe. Now let's talk about the short physical performance battery, which our previous speaker was also saying, and I'm also speaking on this. So what does it mean? It's a very simple, brief, objective clinical test used to evaluate the lower extremity physical function, number one, balance, number two, and mobility. Three things. One, function, how well we can function, the balance and mobility in the older adults. This is developed by the National Institute of Aging, and it takes around 10 minutes to complete. And it's very important because it has a very good predictive value for future disability, falls, and mortality. So if this is positive, then probably our patient may have higher occurrence of falls, more disability, mortality, needs attention to be paid on this factor and to be looked into so that we can control this. So the three core tests in this, one is there are various scoring in that. And the one is the balance assessment. In the balance assessment, it's a simple, the patient is asked to stand for 10 seconds in three increasingly difficult positions, One is a feet together, something like which we look for the cerebellar signs. If the residents who are listening, then they would say that it's something like a cerebellar signs evaluation, because balance is one of the main features of the cerebellum. But then sarcopenia further aggravates it. So the feet together, a semi-tandem, and then a full tandem walking if it is done. So that is a balance assessment, and there is a scoring from 0 to 4 in this. Then there is a gait speed. The gait speed is a 4-meter walk test. In this, the participant walks for 4 meters at his usual comfortable pace. It's not that because he's doing for you, he has to begin walking fast. No, at the pace which he usually walks. And this is tested twice, and the faster one is used, and how long it takes accordingly, the scoring is done. Then the third one I feel is very important is a repeated chair stands. An elderly individual in this proximus muscles, that is the most important point where he has a problem. Standing above the chair with the arms crossed over the chest. He should not be, and don't go by this picture. In this picture, he's taking help of the sofa. No, he's supposed to cross the arms across the chest and then stand up. And then he has to stand repeatedly 5 times. How much time does he take? He should not be taking more than 15 seconds. So how much time he takes, if that you can note accordingly, you can score. So on the basis of these 3 tests, the short performance battery test can be looked into, and then we can accordingly decide whether he's a poor functional impairment, or he is good, he is robust, or he has a moderate physical performance test. So these are the ways in which we can do. We can do clinically as per the physical disability or the limitation of his activities. Now coming to the other part of the assessment of the framework overview. We should realize that if we look into the muscle mass and the muscle mass, if we want to see, then we have to go in for some different tests. We cannot look into the muscle mass just by asking the patient to walk around. We have to do some tests. The gold standard components for looking into the lean body mass, you must have seen many times it's written LBM. So lean body mass imaging becomes very important. Second is the anthropometric measuring technique. And third is the muscle strength assessment. So all these go on to evaluate whether there's a loss of the muscle quantity, loss of the muscle strength, and loss of the muscle function. So these are the gold standard components, and we need a multimodal approach necessity. We may need the help of other tests also, because this is somewhat challenging, and imaging techniques are not that easy, and the clinical feasibility also is not always possible, but we might need in certain situations a multimodal approach necessity. What should be our target audience? What I mean by this is that all the professionals who manage chronic disorders should have this structured framework for diagnosing sarcopenia and then acting accordingly to have improved outcomes. Now, looking into the imaging modalities, the gold standard, if we say the available imaging tools, the gold standard we say are the MRI and the CT scan to look in for the lean body mass. For the lean body mass, CT MRI, then we have bioimpedance analysis, we have DEXA, which is the dual energy X-ray absorptiometry. CT MRI, they can measure the muscle mass and are very good indicators. And they are the positive pros, if you say, is they are less prone to variability with the muscle mass. They do not usually give errors. This is especially what I'm talking about the suitability in cirrhosis, because cirrhosis is one condition where the patient has a huge ascites, but the muscle mass is very much wasted. So in that, CT MRI becomes important because here the volume status is affected in cirrhosis. So in many conditions, like in heart failure and cirrhosis of liver, the volume status would be different. You know, the volume status is different because of fluid accumulation. So that affects the precision. But CT MRI in that, the volume status is not dependent on that. It is independent, so it can give the good results. But the cons are, it is very expensive. You can hardly ask every patient to go in for that. And it is not portable. So the patient has to go all the way there. So that is the cons of it. CTVC, it's a cross-sectional imaging for the precision muscle mass measurement. It's validated, but it's expensive. It's not portable. There's a radiation exposure and requires skill interpretation. MRI is validated, very precise, not affected by volume status, no radiation also, but costly, not portable, again requires skilled interpretation. What happens in these conditions is that they don't have standardized cutoffs also, which may vary. And hence, though your precision testing is good, because the cutoffs may vary, probably your interpretation may not be that good. So a skilled interpretation is important. Many a times that may not be there. So that is the cons of it, negative aspect of it. What about the bioimpedance analysis and the DEXA, which we talk about, the dual energy X-ray absorptiometry? We talk about that bioimpedance analysis. It uses an electric current to assess the total body water and predict the muscle mass. It's portable, it's cost effective, but then it is dependent on the volume status, so may not be very accurate all the times. The DEXA evaluation uses total body scan to assess the bone, the fat, the muscle. So everything is very clear in that. It's brief, it's precise, there's limited radiation, but it is not portable, expensive, and again dependent on volume status. So both these would depend on the volume status and have their own problems with them. Now, what about the anthropometric measures? Now, when we look into the anthropometric techniques, they mainly include the mid-arm circumference, the skin fold thickness, the calf circumference. These are very important and they're quite cost-effective alternative to imaging when we want to talk about the muscle mass, how much the patient has. So, though they have a limitation. What is a limitation? Despite ease of measurement, anthropometry is not necessarily a strong measure of muscle mass due to human error, skin elasticity alterations, aging-related changes in body mass, and technique differences, individual differences in the performer. So anthropometric measures should be integrated with imaging and strength test techniques for holistic assessment. Now, the mid-arm circumference, I'll briefly say, it's the halfway between the olecranon process and the acromion. At the arm are bent at 90 degrees, and the cutoff is 22.5 centimeters. The skin fold thickness, again, it uses the caliper and the posterior aspect of the arm. Again, halfway between the olecranon acromion, and the calf circumference is the maximum circumference of the lower non-dominant leg, bent at 90 degrees. It's very reliable, the cutoff being less than 31 centimeters. So validation. Now, variety of, if you look into the muscle strength tools, now we looked into the muscle mass tools, now looking into the muscle strength tools. Now this becomes very important because this we can do in our setup also easily. A variety of validated tools exist for muscle strength, including the hand grip, the chair stand. They are reliable indicators, and that I will be talking about. And then they have to be integrated with the other lean body mass imaging that we talked about. Now, if we look into the hand grip and the chair strength, what we see is that in the hand grip is measured with a dynamometer. I am sure most of us have it with us, but probably we don't use it that often. The dynamometer is used in the dominant hand and with the base resting in the palm and requiring the maximal isometric effort for 5 seconds. The cutoff being 27 kgs for men and 16 kgs for women. I'm telling you, even when I do it, probably I don't reach to 16 kgs, meaning that we think it's so easy, but when we really objectify our findings as to in these tests, we realize, no, it is not that good. So the dynamometer is a very simple indicator which we should use, easily available for the clinicians in their, and it doesn't take any time. The chair stand, which I already talked about, 5 times he has to stand up with cutoff being, it should be done less than 15 seconds. If it takes more time, it's a bad news. And these both correlate well with the other tests, and then they have to be integrated. So the time a get up and go measure is also there. And the short physical performance battery, which we already talked about. Now, a word about sarcopenic obesity. This is a very confusing term because the person is sarcopenic also. He's wasted, as we say in a general terms, and he's obese also. So this becomes confusing because if you look into the waist circumference and BMI, that is not low, that is high. But still he has a bad muscle strength and mass. So we need to identify this and correct this. In 2015, the fat mass of more than 32% in women measured by DEXA was proposed as the consensus cutoff for sarcopenic obesity. We can remember this. If DEXA shows a more than 32% in women fat mass, that goes into sarcopenic obesity. Now, once we realize that the patient has sarcopenia, or we think that he's my long-term diabetic, probably, what should I do to prevent sarcopenia? So what should be done? One is nutrition. So various studies were done. I could not include all because of paucity of time. Porter-Star et al., they looked into the effect of 6-month moderately hypocaloric diet, which was significantly hypocaloric. The calories were less people showed a higher protein 1.8. The interventions reduce these.
We can't hear you, Dr. Swati.
Okay.
Can you switch off your video? Swati, we can't hear you.
I think there is connectivity.
Swati, can you switch off your video and then? Dr. Princey, can you hear me?
Yes, ma'am, you're audible to me, but ma'am is not audible. We can
So
only
can
see
we
the
take up some of the questions before Swati rejoins us? So I think I'd like to sum up for all of us. Yes. So till Dr. Swati joins, can someone call her? We like to talk about, today we spoke about sarcopenia, sarcopenic obesity. Very interesting discussion by both the speakers, and it has initiated a conversation. And what my message to all of you should be, please start talking about nutrition. Talk to your patients about fats, proteins, and carbs. If you'll realize, Dr. Sunita, I'm really very happy that you started this conversation, because now with the advent of GLP-1 receptor agonist and GLP-GIP receptor agonist, ADA.
So yeah, I think I'm there now. Am I
okay.
audible?
Yes. So let me just complete what I was saying. Yeah, you will complete.
I'll just complete
Swati,
because
I was just
management.
Swati, I was just saying something. I'll complete that. Then you will continue the presentation. So we are trying to reinforce what you said, that sarcopenia is important. our antenna should be up. We should realize that there is something called sarcopenia, loss of muscle mass as well as strength. There is something called sarcopenic obesity. And then we will be discussing how even ADA, ESD, IDF do not have separate guidelines for sarcopenia. Continue, Dr. Swati. Yeah.
Yeah, so I'll just be fast now. So what they found was that there was a significant loss of, they found that there was not very much difference in both the groups. So basically a high protein diet is good. So there should be an adequate protein diet, in short, what they found out. Now, the second aspect after nutrition is very important. Then we have pharmacotherapy. As we were discussing previously, that estrogen has a significant effect. So does hormone replacement therapy has an impact? Yes, it in postmenopausal women, there is a definite change, but HRT did not find in studies to have any benefit on the sarcopenia. It was mainly on the bone mass, which was the benefit, but on the muscle mass, there was not specific change. So this is not an indication for hormone replacement therapy. The other studies which looked into vitamin D supplementation, and they found that there was some improvement in the appendicular skeletal muscle mass, but otherwise there was the handpricks and was not very much. But then we have to be careful about these micronutrient deficiencies, and supplementing them would be a good idea. What is very important is the exercise, and exercise is one factor that has to be really stressed upon, especially in the Indian scenario where we do not exercise even in our younger age group. Our elderly people definitely have very less exercise, so that has to be focused upon. What is seen is that the resistance training, the Kuna et al. Study showed that resistance training 3 times a week, they definitely showed an increase in the skeletal muscle mass versus control. And the resistance training was very useful. Aerobics was a combination alone. It was not that good, but aerobics plus resistance training was superior to both individually done alone. And cardiorespiratory fitness improved with the aerobic exercise. So this is my concluding slide, which says that a step-by-step diagnostic process where we need to assess the muscle strength, the quality, the quantity, and assess the physical performance, integrate where required and where possible with the anthropometry, the lean body mass imaging, strength assessments, and then look into the decision making, into the resistance training, adequate protein content in diet, and correction of the micronutrient deficiencies. We could go a long way to improve our patients with sarcopenia and do them a lot of benefit in their outcome. Thank you very much for your patient listening.
Thank you, ma'am, for sharing your expertise and insights. Now, it's my pleasure to invite Dr. Divya Saxena, ma'am, as a moderator to take the session further. Dr. Divya, ma'am, is a director of Saxena Multispeciality Hospital at Sonipat. She's a well-known diabetologist and a critical care specialist, and a course director of a diabetology course by RSSDI, and also she's also a director of MSc diploma course by University from South Wales, UK. Welcome, ma'am.
Thank you, Dr. Princey, for the warm introduction. And I must congratulate both the speakers for a very well explained topic, very well explained, very well. They both have covered every finer detail of sarcopenia and diabetic women. But still some question arises in our mind. So we have expert and eminent faculties with us to answer these questions, Dr. Meena Chabra ma'am and Dr. Yogita ma'am, where Dr. Yogita ma'am is a professor in HOD General Medicine Department, LLRM Medical College, Meerut, UP. And Dr. Meena Chabra ma'am is a senior physician director, and she is a senior visiting consultant and diabetologist in Sir Gangaram Hospital, New Delhi. So I have few questions in my mind, and I think the audience must also be having, though our speakers explained everything in detail, but still we want to know, Dr. Meena, first from you, that do current diabetes management guidelines sufficiently address preservation of skeleton muscle mass and function? Can you please throw light on this?
So that's what I was talking about, that they don't. So surprisingly, if you see ADA or if you see IDF, or you see EASD, the European, none of them have separate guidelines for management or diagnosis of sarcopenia. But now, with the increasing use of GLP and GIP, in the guidelines, we do hear things like increased protein intake. We do hear about, muscle mass. We do hear about lean mass and fat mass and all these terms. So now, perhaps in the next few years, the guidelines will incorporate, but as of now, most of these guidelines are, done by sports societies, by geriatric societies, and then one guideline that Dr. Agarwal mentioned several times, the Sarcopenia Society. So I think it's very interesting that it's diabetic patients who become more sarcopenic or have sarcopenic obesity, particularly South Asian women, but there are no dedicated guideline based,
As such.
diagnosis nor management. But yes, there are several terms like that. Frailty, it's mentioned that, drugs can cause GLP, GIP in that context. It's there. So now at least all of us physicians, now we are tuned to that. When you read the guidelines, you realize that protein intake is important. You realize that it's your responsibility that when you're giving a GLP-1 drug, it's not just reduction in obesity, which is important. So I think what we should have, which is a non-invasive test, very simple to do, is a BIA. So some of the pharmaceutical companies have bought these machines, and we could insist that they give it to us for a month or 2 months, and so that we can call our patients and do the BIA, the bioelectrical impedance analysis. It's not a gold standard. Dr. Swati gave us details of what we should be doing, CT, DEXA, and MRIs, but she said we can't do it for all. So this is a simple non-invasive test where you could at least, you're tuned to sarcopenic obesity, where you know what is the fat mass and the water content and the visceral adiposity, all that you can see. So I think guidelines will now, and our own RSSTI guidelines, we should actually start writing. So we can be the first to talk about sarcopenia, or perhaps IPF can write some guidelines,
Yeah. Very truly said. No, during in our day-to-day OPD, generally this thing is being missed by all of us. I'm really sorry to say, but it's very difficult to pay attention for everything. But we should pay attention to sarcopenia as well, because many of our diabetic patients are obese. So it's generally missed a point from our patients, and we should,
complain of a lot of fatigue. They say we cannot exercise because of
we should pay some attention. And a very simple thing, simple screening we can do in our day-to-day OPD as well. But at least we should include the counseling part, like protein intake, to increase protein intake, to have a good mix of exercise to increase the muscle mass of our type 2 diabetic patient. Again, another question is from Dr. Yogita ma'am. Ma'am, are we underdiagnosing sarcopenic obesity? We all are discussing for so long, but I want to hear from you that Indian women are being underdiagnosed because BMI-centric definitions fail to capture altered body composition. How many clinicians from all of us here routinely assess muscle strength in women with type 2 diabetes? From your point of view, ma'am.
Ma'am, definitely we are underdiagnosing, and we are not routinely follow these guidelines as we have discussed here. Main thing I do consider here is the change of perspective. Till now we are focusing on the microvascular and macrovascular complications in the diabetes. We are not focusing on the skeletal muscle strength or mass in the diabetic patient, especially in the women. My personal opinion, we have to, first of all, we have to make a structured clinic and an integrated approach to address these situations. जैसे कि मैं बात करूं हमारे LLRM में, we have special endocrine OPD and the general medicine OPD, but they work separately. There we need to address all these things and facilities under one roof, and we have to start multidisciplinary approach under one roof. So despite being a patient may have sarcopenia, and BMI is normal or above, So BMI is not a true indicator of sarcopenia. Thank
Yeah.
you.
Yeah, very rightly said, ma'am. We should have at least, I think many of us must be having diabetes educator with us. So if it is difficult for us to give so much of time to each and every patient, we must educate our diabetes educator, or we can assign this kind of job to one of our staff to ask simple symptomatic symptoms of sarcopenia from each and every patient, so that we can at least clinically suspect that patient must be sarcopenic, and we can
Definitely.
further treat or prevent the sarcopenia to happen in our patients. So now, Dr. Meena, can you please tell that in women with type 2 diabetes, what comes first biologically? Yeah, generally, we know that insulin resistance is the main thing which leads to sarcopenia, and which is the main reason why the diabetic women, is more sarcopenic in comparison to normal individual. So, or declining muscle mass, worsening glycemic dysfunction. What is the main thing which leads to sarcopenia?
We should go back to Dr. Sunita Agarwal's talk. She explained very beautifully that there is obesity, there is insulin resistance. Once there is insulin resistance, insulin is not able to do its job. There is resistance at the level of the muscle, the liver, and the adipose tissue. Dr. Sunita made a very nice diagram and explained that muscle insulin resistance. So glucose is not utilized by the muscle. There is hyperglycemia, less glucose utilization by the muscle. When there is less glucose utilization by the muscle, what happens? The muscle strength and the muscle function decreases, the muscle mass decreases. So she has explained very well that, of course, in Asian women, insulin resistance comes first, and then it leads to this. But also, menopause contributes, obesity contributes, then neuropathy contributes to all these, declining muscle strength and muscle mass. So I think it's a vicious cycle. It's not that, so, and once the patient is diabetic and there is a reduction in muscle strength, further reduction in glucose utilization by the muscle, so the patient goes into a vicious cycle of reduced muscle mass. So it's important. Insulin resistance, of course, is important, but it's also muscle strength decreases. So both, it's a vicious cycle. And I think we should remember Dr. Sunita's diagram, and then we know how insulin resistance contributes to muscle insulin resistance. Of course, we have resistance of the adipose tissue, the muscle, and the liver. But we can address muscle insulin resistance by pioglitazone. Imagine a drug like glitazones, which we've always put in, we've kind of put it in the dustbin, but that can improve muscle insulin resistance, pioglitazone. So they can be used. So I think both are important. And once the patient, type 2 diabetic patient, due to increased insulin resistance, decreased muscle mass, further increases hyperglycemia and goes into a vicious cycle.
Yeah, truly said, ma'am. And Dr. Yogita, can you please tell me that how does menopause accelerate the diabetes sarcopenia cycle in women? And what role do estrogen deficiency, chronic inflammation, and visceral adiposity play in female sarcopenic phenotype? Your point of view, ma'am.
As we all know, estrogen does very diverse function in female body. In postmenopausal state, estrogen effect is get over, and it badly affects on skeletal muscles, even on cellular level, energy metabolism decline, oxidative stress is risen, and so many functions which hamper after the menopause. So it increases the possibility of sarcopenia. As we know, sarcopenia is not merely a age-related disorder now. So especially in postmenopausal women, and super added on diabetic status, these two factors accelerate sarcopenia in these patients.
So multiple factor leads to sarcopenia in a type 2 diabetic, not only a single factor like insulin resistance or the age-related or menopause is causing only. So there are multiple factors which plays major role in causing sarcopenia in type 2 diabetic. Dr. Meena ma'am, our current international cutoffs, I was asking you about hormonal replacement therapy. Can hormone replacement therapy influences muscle preservation in diabetic women? And is the evidence convincing enough to treat our type 2 diabetics with the hormone replacement therapy for sarcopenia? Meena ma'am? Dr. Meena ma'am, are you there?
I think Yogita ma'am can take up this question till
Yeah,
she joins.
Yogita ma'am, if you can take this question.
In a previous lecture of, I think, Dr. Swati ma'am, in many studies, hormone replacement therapy shows improvement in bone and mineral metabolism, but not statistically significant role in skeletal muscles. I think may have
That's right.
HRTs
Studies have done.
not
studies have been done,
beneficial in skeletal.
Yes, in the muscle mass, not significant. Not significant.
Okay, not significant.
Also, Dr. Swati, when we are giving HRT, can you hear me?
Yes, we can all hear you.
Yes.
So also when we are giving HRT, we should remember we have to do breast cancer screening if there's, so
Yes,
as
as such,
risk increases.
yeah.
So I think we don't give many of our patients
No,
unless
it's
there
not.
are menopausal symptoms like flushing or vaginal dryness.
So
HRT
as such, hormone replacement therapy is a very in the past years it was quite in the vogue. It was very much in noise factor was there, but over the past decade or 2 decades, HRT has been associated with so many risk factors that there's hardly very few indications where it is there, and sarcopenia is not one of them.
Ma'am, there is a question in a chat box also from our audiences. This is for the speakers and guest faculties both. Is there any role of essential amino acid supplements in preventing sarcopenia, especially does carnitine play any role in preventing sarcopenia?
So what has been studied, if I can take the question?
Sure, ma'am.
Yeah.
Please.
So what has been studied is that various studies have been done on various amounts of proteins and essential amino acids as well as other micronutrients. They have been done. They have shown some benefit, but not very significant benefit. So we cannot say that you only give essential amino acids. What rather we should remember is that we should give fair enough good quantity and quality of protein to our patients. What happens in the Indian scenario, as such, we are a carbohydrate driven nation and we give less of proteins to our patients, and especially as they grow older, probably some worries do occur regarding the renal status also, and the proteins further go down. But there we have to balance it with the entire patient's condition, his biochemistry and other things, and accordingly we have to see that he gets proteins. And yes, essential amino acids are something which the one doesn't have in our body, and if we supplement them adequately, but then any study particularly pointing out, I could not come across that. So yes, micronutrient deficiencies, supplementations, and a good protein along with exercise, that too a resistance training with some amount of aerobics, and both of them clubbed together properly, a complete framed out lifestyle modification for the patient would be the best.
Swati, I have a question. When the nephrologists write low protein diet, they do give, so then, and that is the time. And the role of leucine is important, but we have leucine in very low leucine absorption from vegetarian diet. So I think milk products are important. Non-veg sources of leucine is important. And now we have more and more young adults coming to us who go to the gym. So in gym supplements, there is creatine. So important is creatine doesn't increase the creatinine, but taking too much of creatine is bad. Parents come and ask us that the children are taking, and gym supplements have it. So I think the answer is that we can give about 3 to 5 grams per day of creatine. But basically gym supplement is not encouraged, but yes, we do have people who are doing strength training, they are taking. So we can't brush it under the carpet. We'll have to talk. But what I emphasize is we should talk about protein intake, particularly in people with GLP-1 agonist or GIP agonist. And we should write on our prescriptions increase protein intake unless they are microproteinuric or have CKD. we must write increased protein intake to at least 1.1 or 1.2 grams per kg body weight. Start the protein conversation. Tell them to download an app where they can fill in their diets and it will tell them how much protein, carbs, and fats they have taken. So even if you don't have a dedicated nutritionist, you can do it by, introducing them to some certain apps. You have Healthy Family, you have other apps. So at least the patient knows that he has to increase protein intake, or you can have posters in your clinic saying that nuts are a good source of vegetarian source of protein, or dairy, curd, low fat curd, protein intake in tofu, and of course we know non-veg sources of protein. So I think I would like to emphasize that we should start a conversation about nutrition, and it is not just the dietitian's job. It's our job. If we are writing drugs which can cause sarcopenia, because definitely GLP, GIP not just decrease lean mass, they definitely decrease, they not just decrease fat mass, they do decrease lean mass also, we've noticed. So we have to encourage our patients to increase protein intake.
Okay, that's really great. A word about Yogita ma'am, the international cutoff for muscle mass and grip strength. Is it truly applicable to Indian women also?
In
What
my
do you say, ma'am?
in my opinion, ma'am, these are the data based on their studies. We have to we need more study on our population, community-based study or the hospital-based study. That as I am working in medical college, many theses, we can give thesis to our candidates to collect real data of our population, because these are the cutoff value based on their study.
We still have to find out.
We need to collect Indian data. In present scenario, we have to follow Asian cutoff value in our patients. But in my opinion, we need to collect our data in coming years, definitely.
So here I would like to, Dr. Yogita very rightly pointed out, and international cutoffs, that's exactly what I was saying. Even I tried with the hand anemometer when I do it, I am not able to reach the cutoff which they have mentioned. So because Indian women have a much smaller body habitus. Our body habitus is very different from the European and the Caucasians which we have. So our height adjusted muscle mass is also different. We have different strength profiles. And so we should shift towards population specific data. The shift towards population specific data is important for Indians, for Chinese, and for the Japanese and all the other populations as well. This becomes very important, particularly when we talk about the hand grip strength